All right, I think we can get going. I'm going to start with the research corner. I'm going to cover that for Jonathan because he's not able to join us. So today the topic for the discussion, as well as for this is how we do it, and the research corner is the open notes in pediatrics. We did this a while ago when all this movement started, and given that there were some questions in the listserv and it's been a while, we thought it would be nice to revisit. So Jonathan reviewed this article and was going to present it here today for all of us. And what he found in this article is that, well, obviously, what we all know, that 21st Century Cures Act final rule mandated sharing notes electronically with all patients. And the open notes movement is the sharing of medical notes via the patient portal. What the article found is that the complexities around confidentiality with adolescent populations in pediatrics made this have a slow adoption of the open notes. So the bulk of the research has been done in adults, not in pediatrics. And this study was done with parents and guardians of children ages 0 to 11 who had access to open notes. And again, the adolescents under proxies were not included because of those complexities with the autonomy and confidentiality pieces. 89% of the families were surveyed, the family surveyed said that they understood the notes from their physicians. I'm not sure though if this study included behavioral health provider notes. Anyway, 80% found the notes usually accurate. 15% actually contacted their clinicians after reading a note, and 97% of the patients felt the same or better after reading the doctor notes. Here are the results. The sample was 159. These are the questions. How often did the notes accurately describe the visit? As you can see, always or usually, except for some people who answer do not know, just a very small percentage, never. Easy to understand the notes. No one found it very difficult. Some were undecided. Did reading the note change the way you feel about your child's doctor? And many answered much better, somewhat better, or neutral. Did you ever contact your child doctors about what you read in the notes? And here are a few that answered yes, but the majority said no. Open notes were well received by the parents of pediatric patients responding to this survey. And again, mentioning the given adolescent confidentiality rules, more research is needed to actually assess the implementation and implications of open notes in adolescent populations. This research provides evidence supporting the benefits of open notes for pediatric patients, while also assuaging concerns from the clinicians, which is the topic for today. So with this, I don't know if you have any comments about this, or if we should just, Matthew, let you do this is how we do it, and maybe have the discussion all together at the end. You want me to share the screen for your presentation?
Yeah, I think we can go ahead and go, and then ours is just meant to spark conversation anyway, and so maybe we do that and then have a larger conversation about both topics. Does that sound good?
That sounds great.
Let me find yours. All right, okay.
that okay?
Yes, perfect.
Okay. So thank you all. I'm Matthew Tolliver. I work as part of the Institute for Integrated Behavioral Health at East Tennessee State University and work as our Director of Behavioral Health in our Department of Pediatrics. And I'll let my co-presenter, Dr. Dodd, introduce himself.
And I'm William Dodd. I'm a pediatrician. I'm actually med-ped, so I practice both pediatrics and internal medicine and treat many of our adolescents in the Adolescent Clinic here at ETSU.
We were in a community health fair event over the weekend, and Dr. Dodd's protecting his privacy here during that. So he was working and doing outreach to adolescents at the health fair, working on role plays about types of healthy relationships. So we thought we'd include that. Our disclosures are just that we're not lawyers, and so this isn't legal advice, but this is just what we've researched and wanted to present to you all for consideration and discussion. But we wanted to talk about the topic of adolescent confidentiality and how it comes up in especially pediatric or primary care settings, because it comes up a lot. Just for context, we're zooming in from Johnson City, Tennessee. That's in the northeast part of Tennessee here. It's a beautiful area, and we encourage you guys to come and visit us. Our clinic is in the Johnson City practice of our Department of Pediatrics, and in the College of Medicine that we're situated in, we've started a couple of years ago this Institute for Integrated Behavioral Health that tries to coordinate the behavioral health consultants that serve a broad range of clinics within the university setting. And so this is where we are. We kind of work out of the bottom building of this clinical education building here in our Colon College of Medicine. And we're a residency training clinic, like many of you may be. So we primarily serve Medicaid recipients, and we have 3 full-time behavioral health consultants in our practice, 2 of which are clinical psychologists, and 1 is a licensed social worker. And we have other nutrition and other medical specialties embedded in. So that's kind of the context that we're coming to you from as an academic health science center that's trying to figure out some of this stuff. So why are we talking about this topic in particular? And why is it important to talk about? Well, one is that, of course, we're all on electronic health records now. And because of that, that brings lots of convenience and opportunities for enhanced communication. But as we all know, it can also bring a lot of barriers too. And when you're thinking about adolescents in particular and who has access to the health record, the parent, the adolescent, the providers, that can be a recipe for needing to really iron out protocols to make sure that we're not inadvertently breaking confidentiality that we're promising during clinical visits. Another thing is the Cures Act, which came into effect relatively recently. And I listed some references here if you all want to look at it a little bit more. There's some guidance from the American Medical Association and the American Psychological Association in just how to navigate some of that. There, in the Cures Act, there's something called the information blocking rule. So it means that you can't just go in and refuse to give access to records, including mental health records, unless it's checking some specific boxes. And so it can get a little bit complicated when you're talking about adolescents. So that should be another thing on your radar. And then Chus just talked about the implications of the open notes movement, right? Of this movement to encourage sharing of our notes with our patients as a way of enhancing outcomes and improving that relationship. So when you're meeting with the teenager, there can be this sort of tug of war that can go on, even on a broad level, but even within a single family that you're meeting with, right? This parental desire for access to information about their adolescents so they can take care of them appropriately and keep them safe, which makes sense, but also balanced with trying to make available confidential adolescent health care services, which we know is the standard of care and that is associated with more positive outcomes if adolescents have that confidential relationship with their provider. And when we're navigating this, though, you can sometimes feel a little bit at a crossroads, and it really requires knowledge of your own professional ethics and your kind of guild's ethics that you're being held to, and also knowledge about federal and state law. And sometimes there's a kind of those help you clarify a situation, and other times it can make it feel a little bit even more complicated. And so having a lawyer on speed dial can sometimes help with navigating some of this. Even last week, there were some situations that came up that I had to consult a lawyer about. But if you look at what kind of laws are out there that are related to this, HIPAA provides kind of a floor of protection related to confidentiality and privacy. And there's three main reasons why parents might not be able to access their adolescents' health records, because generally it's presumed that they do have access. One is when a minor obtains health care at the direction of a court. Another one is when the parent or caregiver agrees that the adolescent and the clinician can have that confidential relationship. And then the third one that HIPAA spells out is when a minor can consent to the care themselves, and the parent isn't required by state law to consent for the child or for the adolescent. And then if you're interested, there's some further readings down here that we'll distribute if you want to get a little bit more into detail about some of that stuff. But another resource we wanted to provide to you was this article that came out in Pediatrics in June of last year that is state by state variability in adolescent privacy laws. And I found this pretty helpful. This is just kind of clipping a few examples from that article in a few different states. We're Tennessee at the bottom, and it has across the top and columns different types of information that you may find that you're needing to consider keep confidential. For example, in Tennessee, 16-year-olds and older can consent to general medical care. If they're 14 or older, they can consent to immunizations and dental care. We don't have a particular policy about sexual assault evaluations, but youth can consent to STI testing, HIV testing, contraceptive care, prenatal care, and substance use treatment without parental consent. And then in Tennessee, if you're 16, you can consent to mental health care without parental consent. And at that point, you're considered to have the same rights to confidentiality as an adult would. And so that definitely has implications for how you treat the information that those youth disclose to you. But as you can see, it really varies by state. And so we talked about those floor of protections from HIPAA that really interacts with state laws in particular. And so it makes it pretty difficult to have a unified standard to even discuss in a setting like this. And so we would just encourage you to seek out this article and kind of get up to date on your particular state's privacy laws related to adolescents.
So if you look at the major medical associations, they're fairly explicit in their guidance on this topic. Society for Adolescent Health and Medicine is the preeminent adolescent medicine society in the US. And they say that confidentiality is very important. They say it's an essential component of healthcare because it's consistent with their development of maturity and autonomy. And also adolescents may avoid care on sensitive topics if they are faced with the decision of breaking that confidentiality with their caregivers or other important people in their life. So next slide, Matthew. And if you look at the other major medical associations in the US, the American Medical Association, ACOG, which is the obstetrician gynecologist organization, and the American Academy of Family Practice, they unanimously agree that adolescents warrant some form of confidentiality in their healthcare, specifically around sensitive topics like reproductive health or substance abuse or mental health. Which raises the specter, and I know this is the topic of the day, of documentation. You know, documentation serves many different purposes. I think we're all familiar with some of the more limited documentation that's warranted for billing. So sometimes you'll see a note from a clinic that's just stuff that's been pulled in from the medical record. You're not exactly sure what occurred during that visit, but it warrants reimbursement. So sometimes you'll see that. There are legal considerations. So the medical documentation is a way to shield yourself from liability as a physician. And then there are also patient care considerations. So communicating with yourself in the future, communicating with other providers of medical care, and communicating at this point with the patient or even their families through the open notes. So it's a multifaceted tool and a multifaceted element of all of our work in any field of patient care. There's a really interesting case that was discussed in the AMA's Journal of Ethics a few years ago regarding a patient who was admitted to the hospital with pneumonia. The resident took a very detailed history, including a detailed sexual history, and somehow confidentiality was broken with the patient's sexual orientation when it was not really relevant to their medical care. And they had a very interesting discussion after this about how there is no legal mandate that every discussion that occurs during a medical encounter requires documentation, as long as a paraphrase of that conversation kind of maintains the essence of what you talked about. And then there are some harms of vague documentation as well. Patients may receive inadequate medical care for their risk factors. You may have to breach sensitive subjects repeatedly if you don't have a good memory, which can cause harm to the patient. In my personal practice, if I have an adolescent who divulges something that is not relevant immediately to their medical care that they request confidentiality on, like let's say sexual orientation, but they're not sexually active, or you know, some mental health issues that don't rise to the point of requiring care, and they request confidentiality, there is a concern that documentation might break that confidentiality. And so there are ways of paraphrasing, for example, discussed sexual risk factors, sexual orientation and status, ways to prevent STIs, healthy relationships, rather than patient express that they are homosexual, and documenting explicitly within the note. So it's kind of one of those areas where there's sometimes no good, clear answer forward. Dr. Tal? All right, so here's an example of a patient encounter. I see a 16-year-old female in adolescent clinic for a well adolescent check. She discloses the following to me while the parent is out of the room during the head's exam. Every adolescent gets a confidential discussion. She is gay, so she is attracted to members of the same sex. She is sexually active and would like to go on birth control medication. She needs STI testing. She uses cannabis occasionally. She is depressed, and she is so depressed that she has occasional thoughts of harming herself without any plan or intent or means. And I say, Dr. Tolliver, could I get your help?
So, I mean, I think everybody has to understand their state laws enough to know what do you know, how does this play out, right? And what are the factors that in your state that you can keep private, like Dr. Dodd was saying, how do you document a case like this, right, to protect somebody's privacy? You know, how do you navigate it if the parent is reluctant to leave the room in the first place, right? So it's kind of this overlap, I think, of how do you have really strong clinical skills, knowledge of professional ethics, knowledge of the law, and I would advocate for, you know, clinic policies that anticipate these types of situations so that, you know, it's not, so that everybody kind of knows this before something like this happens. And the other point I was going to bring up is just not just the provider-patient aspect of this confidentiality, but what about when you're working on an interprofessional team? What about when you're working with a behavioral health consultant and a medical provider? Maybe I go in and gather half of this information from my behavioral health consultant visit. And if I go out and talk to Dr. Dodd about it, because I feel like it's relevant for the team's care for this patient, if we're not on the same page about our professional ethics and about you know, what his thoughts are on about disclosing certain things to parents or not, I could really get burned in that kind of a situation potentially, right? Where I promised confidentiality to an adolescent, and then I told Dr. Dodd, and he felt like, no, we've got to tell the parent about this. And so, you know, you don't want to get in a situation like that, right? Where you have these disagreements, maybe in professional ethics, that play out for a particular patient. And so one of the things that we wanted to talk about was just, it's okay to have differences of opinion. It's okay to have different professional ethics, but how do you kind of proactively work those things out and kind of develop pathways and resolve any of those differences before you get in a situation where you're standing outside the exam door, you know, and you're trying to figure out what to do next. Dr. Dodd and I work a lot together, and we actually don't have very different practice styles related to this kind of thing. But I mean, if you're in a new clinic, if you're not as familiar with the medical providers or the behavioral health providers that you work with, it's definitely something that's reasonable to come up. Dr. Jay Schenker is another pediatrician that's on the call with us. And so we work a lot with these, with adolescents together. And so we wanted you to kind of have this case to think for yourself, you know, how would I navigate this personally with a patient, but also like, how would I navigate these topics that come up within my interprofessional team? Anything else, Dr. Dodd, on that one?
Oh, no, I think that covers it. I would say I'm married to a psychologist, and I can, I think both physicians and psychologists have strong sets of professional ethics, but there are certain situations where they seem to be different.
And I'm married to a pediatrician, so we're a good team in that way. But so kind of to close, we just wanted to use this to kind of prompt future discussion for the rest of our hour and think about, you know, these are maybe the different kind of bullet points that you would want to think about in your practice that might be kind of potential sticking points or potential problem areas that you would want to develop some kind of pre-thought out plan for. You know, the patient portal, right? You know, who has access and when, and making sure that's very clear. What do you do when teens come into your clinic seeking care without parental consent? How are your consent to treat documents structured? And do they account for some of these things that we've been talking about and some of those state laws that we reviewed? How are your note types structured? And, you know, what are the implications for a release? If you're a mental health provider, are you writing psychotherapy notes, or are you writing progress notes that doesn't have the same level of protections? And then we talked about, you know, just anticipating maybe differences of opinions between interprofessional team members of how to navigate this kind of thing. And then on the provider level, Dr. Dodd talked about, you know, how are you going to document this stuff, especially in the context of open notes, in a way that maintains people's confidentiality. And then kind of thinking through, are there areas that you need to brush up on in terms of your clinical or communication skills, and just being able to navigate these difficult situations with families that come into your practice. And then, so I think the overall take home points would be, you want to know your state laws, and that the laws, even within the same state, can vary based on the type of the care the adolescent is seeking, whether it's sexual health only or mental health or medical. Being aware of the differences in professional ethics, working with your team to build clinical pathways, and then explaining your approach clearly and effectively to families and teenagers. I think that's all we had. So we're happy to discuss from here a bit. Chus, I'll turn it back over to you.
Thank you so much, guys. That was great. So I don't know if anyone has any questions or any comments or scenarios like the case that Matthew and Will were presenting. There are so many layers to it, so please just jump right in with whatever thoughts you have.
This is Gayatri Shankar. I'm also from ETSU in Johnson City, and I agree there are just so many layers to it. One other little cog in the wheel that I want people to be aware of when it comes to records release and types of notes and psychotherapy note versus, what kind of note. And your EHR team, even if you're not aware, the EHR team on the back end has notes usually set in like different levels of confidentiality and release. I think if you're asked for a release from the court, everything goes, but otherwise there are certain levels of release that are set on the back end. But one other thing to also remember when it comes to sexual health and enabling kids to take charge of their health, and maybe they come asking for confidentiality, is for them to remember that as long as their parents are still part of their insurance, even if we are confidential, if we keep the note confidential and we promise all of these other pieces, one part of what may happen is that what's called the EOB, that explanation of benefits from that insurance, will go back to the parent. And often it has the diagnosis code listed on there, which they may then be able to look at and understand the complexity or whatever that piece is. So I think as a provider, that is something that we have to also keep in mind. There are certain insurances that for sure send an EOB to whoever's responsible for the insurance.
Very good point. We deal with that too. So thank you for bringing it up.
I'd like to mention a practical matter that I ran into as a parent when my daughter turned 13. All of a sudden, I had been managing her chart for 13 years using my chart, and all of a sudden the doors closed. And the practical matter was that I could no longer reorder her prescriptions because I couldn't see her prescription list. Now, there was a workaround. She had to give me explicit permission, which we sent to Kaiser and opened that up for me again. But I'm just thinking that sort of thing becomes a barrier to care when, the child's not going to be reordering prescriptions for herself. And if the parent gets blocked and the prescriptions are missed, who knows what the consequences might be.
Right. I think that brings, a lot of things that were presented today, including also what you're saying, David, one can argue on both sides of the issue, right? What contributes or gets in the way. So I think we have a chat about this. Gina, our practice will cover STI testing if the adolescent requests that it remains confidential, so that doesn't show up on the parent's insurance. Amelia says that she also does something similar if it is covered by the state.
And I think there is something called coverage through Title 10, which will enable them to access confidential care, but you have to know whether your clinic kind of follows those procedures or not. So I think that's important to know in talking to the teenager and kind of outlining it for them.
Thanks.
How are folks documenting pregnancy tests if a teen has requested or said they're not ready to share that risk with the parent?
So I can speak to our clinic. Any sort of test that we order is automatically pulled into the chart. So there's no way to, we just have to rely on the confidentiality protections that are built into the chart as a whole, which are, in my view, less than ideal. It's kind of a big system that is built around billing and medical care first, and then this small subset of confidentiality concerns is kind of developing, So.
Thanks.
Hi, this is Viking Hidberg. I'm a pediatrician who works in a family medicine residency in New Hampshire. And sort of adjacent to Dr. Haddock's question or comment, we're exploring a potential where beginning around 13, there's a discussion in the primary care visit with the parent or the guardian and the adolescent as who has access to the portal and the records. And there'd be the option, it could be the parent only, it could be the parent and the adolescent, or the adolescent only. And thinking this sort of fits developmentally, and also recognizing how many holes there are in confidentiality that, if it's not explicit there, there's something that's going to fall through the cracks. And I'm wondering if anybody else has done a similar process.
I think I can speak for our clinic in that by default at 13, it's the adolescent whose numbers are there as far as the person getting the calls or being texted, etc. However, I think it is a conversation that we have to be more thoughtful about having at age 12 or even at that first 13-year-old visit, saying, hey, when you go back out to the front, make sure if you're still involved in your child's care that you have them give you access to the chart. Because I think that's sort of the standard of care now, is starting at 13, that confidentiality piece dictates who gets the chart.
Because currently I work in Concord Hospital in New Hampshire, and at 13 the portal goes away, which makes communication difficult for everybody. But if the parent requests the records from HIMSS, they can get the record and all of it. And they're doing screening, including for SBIRT, where you're asking about substance abuse, and also domestic violence. And it's a very challenging environment because, if you're screening for domestic violence and they have a question that, yes, I'm unsafe at home, and the parents get those records, you could really create a major safety issue for that child.
And depending on the size of the health system you're in, it may be a bigger lift to even change policies around some of that stuff. But I think just at a basic level, every provider being able to understand at least what does go to the portal and what doesn't, at least helps you in that moment know, how am I going to document this visit of the information that I have? And I think it gets even harder though if there are the structure of the note forces you to make some of those decisions versus like a more open free text box style. But that's what we've been trying to do in our clinic, of just like even understanding what is the current system, so that we know we can kind of anticipate maybe when some of those issues might come up.
Yeah, challenging issue. And it was a very nice presentation, by the way. Thank you, both of you, for all of you.
I have a question for all of you. Has any of this changed the way you document, the way you write your notes?
I've had very specific cases, I would say, where my documentation has changed based on the patient's confidentiality needs. And I work in a private practice, and integrated behavioral health is fairly new to me. So I think I've been I get a little worried about our system, and that I don't have a high confidence that my notes are not going to get released. So like I've had parents request records. Like if somebody requested records, and I'd be curious to know if other practices, I don't feel confident that my notes are not going out with record transfers. And they'll say like, you can call and just ask for your records and you can bring them to your new practice if you want. So I worry a lot about that, particularly with kids whose families are separating, because then I get notes that are put in the middle. Or I've had a patient who disclosed that they were transgender but didn't want their family to know, and they were close to being 18, but technically their parents still had access to their records. So the way that I documented that in my progress note was very generic, so that it wasn't apparent to anybody who may have accessed those notes. And then I had another encounter where I had a patient who didn't want her family to know about certain things. So we added her to the portal as an adolescent. And when she logged into the portal, she realized that she could see, and her family could see, my notes when I did a warm handoff for word for word for word. So thankfully I had not documented anything I didn't want anybody to know. But that was really stressful. And she could tell every time her parents logged in, and that particular patient had an eating disorder. And so then we realized she could see her weights on there, even though we were trying to do blind weights at the time. So I feel like I really struggle with the documentation thing being in integrated behavioral health in a private practice. I feel like our EHR doesn't do a great job at being able to give us the protections to separate things, and makes me a little nervous.
Right. I mean, what you're bringing up speaks about what Matthew and Will were presenting, and the infrastructure that you have behind in the systems that you work, right? You don't even trust that is functional, or that the rules that they have in place, they protect your part of the note or your notes. So that's a huge one.
I don't know what system you're in, but talking with like your portal providers, I know we use Ocean Epic, and when anybody has a diagnosis that falls under like the eating disorder realm, it just automatically removes access to weights on like printouts, like the ABS that we give out and things like that. It will just take that away and make it a lot harder to find those on the app and stuff. Of course, if they request their records, they're going to get them, but it won't be on like the portal piece, which is nice. It doesn't include like body dysmorphia, which is unfortunate, but it does, or body image problem. It does body dysmorphia. Oh, I'm not sure. We've been having some issues with that one, but anything like eating disorder, RFID, that kind of stuff, it will take it away from them.
Well, there is a question from Rebecca for mental health providers on the call, specifically related to confidentiality and provider care to teens who could be at risk but does not fall into the sexual health or chemical health. Rebecca, are you referring to suicide risk, or what type of risk are you looking for an answer on this?
Hi, can you guys hear me?
Yes.
Okay, great. Sorry about that. I'm on my phone. My question is, as a therapist, I'm curious about like kids that are, questioning their gender identity or sexual orientation, or things that, maybe they have thoughts of suicide, but no intent or plan. And they're very, very concerned about sharing that with their parent. I'm just kind of, I feel like there's a lot of gray, and I recognize that that there will still be a lot of gray, but I'm just curious what other people's practices are.
Who wants to respond to Rebecca?
So
I can talk about what I do. Oh, go ahead, Dr. Dodd.
Oh, I was just going to say, I would always, for something like suicidality, I always really encourage adolescents to be transparent with their parents, and really try and build that relationship to a point where they might feel comfortable approaching their parents. I would not break confidentiality without their blessing for something that's not immediately harmful, but really I would encourage them to do so. And then our EMR specifically has the capacity to, we have a special type of note that has increased privacy protections that we can use separately to document any like critical concerns outside of the general patient record. It's still, I believe there's some ways that it can still be accessed, but it's definitely more protected than the general chart.
Yeah, I would second that. We have what we call it a confidential services encounter, and it allows us to have a little bit more protections for things like that. When we talk to I don't know what state you're in, but mental health is covered. It's a protected entity after 13 for teens in Washington, and so we're able to put some stuff in our notes, but we make it very clear that you don't change any of the SOGI information in the physical chart until they're out to their families, specifically for like trans, or if they're talking about like their sexual orientation or something like that. You normally would change the chart so that it matches and has the right name and stuff like that. But if they're not out to family members, then we only put it in our note and use that confidential side of things. We don't change anything on the patient-facing side of the EHR so that they don't get outed to families.
I'd like to mention another potential leakage of confidential information as part of the 21st Century Cures Act final rule. Hospitals are now required to send ADT messages to the primary care provider. For those of you in hospitals, you know how much information is in the ADT message stream, includes lab results and all sorts of things that will now be pushed automatically to the primary care practice, where the protections might not be carried over. So that's something you should be aware of and check out in your particular institutions.
Someone was asking about what's the node called for the confidential node. Amelia's responding. It's called Confidential Services Encounter, OCHIA. Epic, okay, sorry.
Yeah, that's our system, Epic Ocean. It's our small FQHC version of Epic. We don't get the whole cool thing. We get the smaller package, but it's still great.
And you know, as a mental health provider, if you're writing psychotherapy notes specifically, then those do have extra special protections. But if you're intermingling start and stop times and diagnosis and plan and functional status and things like that, then it's not considered from a HIPAA standpoint, you know, a psychotherapy note. It's probably considered more of a progress note. And so sometimes, no matter what you call that note in your system, it might kind of relate to, is this kind of fall under that designation of a psychotherapy note within your record, if it's kind of a separated, protected thing where you're just documenting the contents of the conversation.
We have used Epic as well. Well, not that Epic, but the regular Epic. And what we have is the sensitive button to protect the node if we think it could be not convenient to share it with patient, but we don't have a different type of node, but just a button to protect the existing node. I don't know if others have that too.
Excuse me, just to add to that, this practices I'm working with that, you know, where they document in Epic. So if it's not specifically in the note, but there's information that they want to share with the rest of the care team, there's a specialty note that's available to our version of Epic that doesn't go into a note that's released, but can be, you know, a form of communication with the other care team members. That's part of the record in that way. So I know different practices are utilizing those spaces as well.
Thank you, Don. Are there more questions? I was hoping we could, oh, go ahead.
Oh, I was just going to say, I was wondering how other folks just approach the patient and family education component of this, because I think from a prevention standpoint, that could reduce a lot of problems on the back end, right? If we can find the best way to be able to introduce this concept early teenage visits, to be able to kind of couch it in developmental progression. And I didn't know, I mean, every clinic might do it a different way, but just thought we could hear how other folks approach that. Of do you talk about, like Dr. Jay Shanker was saying, do you talk about the portal? Do you talk about this as part of a well child check, or do you have kind of team protocols or clinic protocols for how you help that transition from childhood to adolescence, and what that means, and the difference in relationship between kind of the type of relationship you would have with the team there?
We just switched to Epic, and so I work in a pediatric integrated care and a family medicine integrated care clinic, and we're now having this conversation because our previous portal, like, nobody used it, but now that we have Epic, people want to use our portal. So we're having this conversation much more explicitly with families. And I know a lot of our pediatricians, and I know myself as a psychologist, I'm talking to kids starting at like 10, 11, 12 about like what confidentiality is going to look like. I know a lot of our pediatricians just have historically had kids do a little bit more of their visits as they get a little bit older, to kind of prep them for like when parents step out when they turn 13 and things, for like their confidential portions of visits. So I think a lot of our pediatricians are just adding that into that spiel when they start talking about their autonomy as they get older and their role in their healthcare. And I know we've been having really, like, I have an explicit conversation with my kids each visit about confidentiality. And then one of the things I also ask is like, is it okay for your parents to know you came, versus is it okay for them to know the content of your visit, and really explicitly talking about that difference, because that changes a lot of things, right? Like if we can send reminders to parents and they can get an EOB that says psychotherapy, but it doesn't have their note, like, cool, that makes life so much easier. Because then it's just like clicking the sensitive button or doing something like that. And then like the content is safe, but like we can still send messages. Whereas if family can't know that they're coming in for the visit, they can't get an EOB, they can't know any of that, that's going to change the way we document, the way we schedule, the way we do a whole bunch of stuff. And so just having those conversations more frankly with teens.
I was curious to know how many of you have had, how frequently you have conversations with your patients when that time comes about the reasons why they don't want their parents to find out X, Y, and Z. You know, what are you doing with that? Because I hear the preoccupation, but I also think by default, these laws frame the conversations for us as if it were something negative to share or to give parents access. So there has to be an effort sometimes to balance it when that is not necessarily the case. And I'm wondering, how do you do that?
Sorry, I don't know if could you repeat the specific question out of that?
What are your conversations with the patients about reasons for them trying to protect the information from their parents or not? What are those conversations like?
Yeah, I just kind of talk to them about what it is they're concerned about or what they're worried about, what confidentiality looks like in our state, what like the limits to confidentiality are. So like if you're going to hurt yourself or somebody's hurting you, I do have to say stuff, you know, that kind of thing. And then I'll just like really clearly talk to them and just be like, hey, you know, because a lot of them are like, you can't tell my parents anything. And so then it's like having to like just kind of talk about like, what does that look like? And I'll just have a conversation kind of like I was just saying, where we'll just kind of talk about like, what are you worried about? What are we thinking? And then if they are just really worried, I'll just use that sensitive and I'll do everything confidential. But I think the big shift was like checking on if it's okay for family to know that they came for a visit versus can they just not know the content of the visit? Because usually it's they just don't want them to know the content. Like mom drove them. She knows they're here. She's out in the lobby, like she's aware. So we can bill and we can do all that kind of stuff. It's more just the content piece. And then having a conversation, like Dr. Dodd said, about just kind of encouraging them to be open with family, to share things, to have that open communication piece. I usually try to have like a parent at the beginning of a visit or at the end of a visit for a wrap up, unless of course they're coming in for services independently without family knowing at all. But trying to like talk about how do we bring your parent or guardian in to this process without sharing all of the nitty-gritty details. And usually there's obviously some things that teens are like, oh, no, thank you. Please don't at all. But I feel like sometimes if you have that conversation, you can you can get them to be like, okay, you can tell them like general things, but don't tell them like the specifics. And you can help them by being like, how I want to help your parents be the best parents, right? And I want them to be able to support you. So how can I help you help your parents do that? And sometimes they're like, oh, well, that would be useful. And so you can kind of get their buy-in that way too.
Thanks.
I take a similar approach too, where it's at the, when before I bring the parent in, talking with the adolescent of, okay, like of what we talked about, what should we summarize for your mom today? Like, do you want to give that summary? Or maybe sometimes they want me to summarize some stuff. So I will give an example summary and say, hey, does that sound right? Is there stuff that you want me to take out of that or add into that? And then, because I think it is important to have parental involvement when caregivers, are stable and nurturing. I think there's some times where there's cognitive distortions that the teen has or something like that, that really, they're worried about judgment from the parent, or they're worried about this or that. But, if you're able to bring them together, it's really the best, it's clinically indicated, right, to have that level of support from family. And so, thinking about ways of, oh, it sounds like you're worried about this. Could we role play? Can we kind of, what can we do to help you, be able to connect you with mom? Because it sounds like this is something she could give you some extra support in. I have had other scenarios though, where I had a 13-year-old boy disclose stuff about his gender identity to me and was worried about his dad knowing. And after meeting with the family, was in agreement, right? Like, this would be, potentially dangerous for you to disclose this, right? So I think it's not like a one size fits all thing, or we can't just say like, oh, we always need to bring them together in that way. Like in some circumstances, I think it has been like the teenager has been correctly, sensing danger or, certain things around disclosing stuff. And so I think you have to be particularly careful in those situations. But I like what Amelia was saying, like, how is there at least some things in terms of like a global treatment plan, right, that you can help communicate without communicating all of the details.
Thanks, Matthew, and thanks, Ina, for sharing the resource to start conversations. I think we're getting close to the end of the meeting, but I have one last question for all of you, which is how many do you use the notes as an intervention now that your patients are able to access them?
Because I'm not sure what you mean by notes as an intervention.
Right, so using it in a way that have an intended result by virtue of reading it or sharing it with them and at the beginning of your next encounter, whatever ways that you utilize that writing to reinforce whatever you're trying to accomplish and working with the child.
I don't specifically like share it. We do have open notes if they want to get on the portal and see it, but I am always thinking when I'm writing it, okay, I'm going to imagine the patient sitting next to me as I'm writing this. And I do probably 90% of my note in the visit. Basically, the only thing left is like the PCP recs, which I'm writing to the provider. And that's probably the only piece that I have to do outside of the visit. So I do try to think about them, but what I'm really writing is more the ABS, the notes, what I'm going to print out for them to take home. That's where I put more of my intervention piece. But that's a cool idea to think like, hey, if they're reading this, how do we build them up? How do we make them like foster the same things we're trying to say in the visit in their notes? I love that.
When we first started this conversation at this SIG, 2-3 years ago, we also discussed collaborative documentation as a good strategy for no surprises, but also to build the treatment plan together and building the notes together, which actually could be really cool for our integrated work. Does anyone want to comment on that? Is anyone doing that?
I do that a little bit in my plan section, but I do choose that could solve a lot of these problems that we've been discussing today. If you're writing the note with the adolescent there.
Mm-hmm. Any last thoughts?
I have a very quick one. There was a few new people on this meeting today, and I sent them a personal message in the chat to get their email address. A number of people did not respond. So if you can either put your email address in the chat if you want to get more notifications about meeting sessions like this, or you can send it to me at jhan@cfha.net, or just look on the website for me.
Thanks, Aki. Well, there aren't any last thoughts. I want to thank Will and Matthew for presenting today, and all of you for coming. And we hope we can see you again next month, first Monday of the month at 12 Eastern Time. And we will send resources your way as always. Thank you so much, guys.
Excellent. Thank you.
Thanks for having us.